every one of you can see it. My topic today is round blue cell tumors. In a sense, I'm talking about round blue cell malignancies. There are a few benign round blue cell tumors which are benign, but they are so few and far between that we don't usually worry about them because they look very benign. They have a benign morphology and benign patterns. And you of course know, if you have already been through a pathology residency or you have been an oral pathologist for any length of time, that this is such a vast area, such a large topic, that there is absolutely no way to touch every aspect of it. There's just absolutely no way. So I'm going to only briefly literally gloss over many of the topics, and even then I might be rushed for time. So toward the end of the topic, you may see me speaking faster or running through the slides a little faster. So the first part of the lecture, what I'm going to do is try to present to you, how do we even classify it? What do we do to get to some kind of bottom line? Remember, none of us are specialists in round blue cell tumors, because every one of these round blue cell tumors now requires NGS, which is new generation cytogenetics, or next generation cytogenetics, or you need to do translocation studies, or at the least you have to do a small panel of immunohistochemistry. If you are fortunate enough, and I know some of you work at places like All India Institute, or you're at a state institution, more so than private institution, you have a lot more leeway in what immunohistochemical reagents or good pathology access you have. Otherwise, you have to go to a private lab. For example, or our lab, I should say, use University of Florida's College of Medicine's pathology department has a lab, so we do not duplicate it. We use them, and they charge us a reduced fee to us, and then we charge the patient for the rest of the immunohistochemistry. And as you very well know, the American medical system, though might be sounds very good outside, right now you can see it is in crisis. And so we also try to keep ourselves limited to a certain panel. We try to do a certain panel. And I hope through the first half of this lecture, you will be fairly well versed in what kind of diversity we are dealing with. It is literally like looking at a population in London, or looking at a population in New York. You have every language spoken in the world, you have every color, every religion, every kind of diversity, and that's what round blue cell tumors are. Just briefly telling you where I'm from, I'm talking to you right now. Of course, I'm at my home, but I'm in this small town north of Orlando, north of Tampa, west of Jacksonville, and of course, way away, 5 hours away, driving distance away from Miami, and about 15 hours away from New York. And as you can see in the map, I am somewhere in north central Florida, far away from hurricanes and tsunamis that might get here. So we might have beachfront property if we do get a large tsunami someday. I don't mean to sound harsh, but now you can see the biggest town that we fly out of is Atlanta. Okay, so this is where almost all flights from Gainesville either go to Atlanta or they go to Charlotte, North Carolina, right here, and then you fly out of there. There has been a new flight that goes to Dallas, Texas. So this is about 18 hours by drive. Okay. About 4 hours by flight. So as you very well know, those of you who've been to America or are familiar with the United States. So I personally trained in Indianapolis. This is where I did my residency long time ago, almost 30 years ago. I did my residency. After I finished BDS in Kolkata, I moved to Indianapolis, and then I was a faculty member in Nebraska, right here in Lincoln, Nebraska, which you can see, almost the map cuts it off. And from there, I used to teach at the University of Nebraska Medical Center, and then I moved to University of Florida. And I've been here ever since. 2 of my 3 children were born here. So this has been a great town and a great university for me. And here is a photograph of the Health Science Center. I'll just briefly orient you. If you are ever come here for whatever purpose, we have an enormously large Indian student population here, by the way, especially in computer science, electrical engineering, mechanical engineering, aerospace engineering. So this is just the Health Science Center. This is the Children's Hospital, which I hope you can, Nadeem, can you see my mouse moving on the screen?
Yes, sir. Yes, sir.
Very good. And this is a brand new hospital. That is the just the cardiothoracic and vascular surgery hospital. You can see a helipad on the top. There's a helipad on the top here. This is the Veterans Administration. This is the Brain Institute. And this big building, the monolith here, is the dental school. And I'll in the next slide. And this is the entire health science complex, which is an enormously well-equipped, absolutely incredible health science center. And this is the College of Dentistry. So basically, if you look at this building on the other side, from this side, this is the view you get to see. My office is somewhere on the 8th floor, actually 10 steps away from this window. Unfortunately, I don't have a window. I will have to murder my boss to get a window. As you can see, this is a solid brick building designed for planes to fly into. All right, now let's start. Small round blue cell tumors is a group of aggressive tumors. They're almost all malignant. And why is it called blue cell? Have you ever thought of it? Small round blue cell tumor. Why is it called blue cell? The most important reason is there's high increased nuclear cytoplasmic ratios. Once you have a high NC ratio, you get a round blue cell. Basically, for example, a lymphocyte. If you think of it, a normal lymphocyte is a blue cell. A normal plasma cell is a blue cell. But there is some cytoplasm. But an epithelial cell, for example, is not a blue cell. It's got a lot of pink, which is why we call it epithelioid or epidermoid, etc. You might have heard of mucoepidermoid carcinoma. It has a lot of epidermal cells, but this one has very high nuclear cytoplasmic ratio. So the nucleus is sometimes bigger than the cytoplasm. So let's say the ratio is 1:1 in a normal lymphocyte. Sometimes you get a 1.5:1. So the nucleus supersedes the cytoplasm in many cases. And as you can see, the category is so broad, which I'll try to cover some of these entities here. You can see a lymphoma can be in this category, carcinoma, many sarcomas, melanomas, which are also some sort of carcinomas, by the way. Those of you I think most of you are in pathology, so you know the difference between carcinoma and sarcoma. One is of mesenchymal origin, one is of epithelial origin, and melanoma is of epithelial origin. And then you come to neuroblastomas, and there are many other tumors that we'll talk about. So mostly, just as a rule of thumb, small round blue cell tumors are more common in young people, unfortunately, whereas some are seen in older adults, such as lymphomas. Lymphomas are rarely seen in young people, whereas rhabdomyosarcoma and several other sarcomas, retinoblastoma, neuroblastoma, anything that ends with a blast is seen more commonly in a child. Just remember that. There are certain lymphomas that are seen more commonly in children, such as leukemia. And many of you might be wondering, why am I calling a leukemia lymphoma? You'll be surprised to know that leukemia and lymphoma are pretty much the same. One of them is diffuse, one of them is more focused. Lymphomas are typically more localized, where leukemias are more generalized and they involve the bone marrow and other tissues. So how do we distinguish these? They can be present both in soft tissue or in bone. How do we know what is what? One of the most important things you can do is use immunohistochemistry. And immunohistochemistry and, of course, electron microscopy. Electron microscopy is much harder because you need special tissue preparation, fixation in glutaraldehyde, and not routine formaldehyde. So it's harder to do. We do some electron microscopy on rare cases, or if you want to publish a paper or something, but it is not used for routine histochemistry. Routine diagnosis. So very valuable information can be obtained just from immunohistochemistry. So an example, if you did CD20 and it's positive, you know you're dealing with a B-cell lymphoma. If you did a muscle marker and it's positive, you know you're dealing with a muscle malignancy. if you do a epithelial marker and it's positive, you know you're dealing with a carcinoma. So on and so forth. So molecular data these days have become next generation sequencing. NGS has become very, very common in this whole aspect. Especially when you look at why is it important. You could say, why can't I just call it a blue cell tumor and dismiss it? Because it'll depend on the size of the tumor. No, you'll be very surprised to know that there are absolutely tailor-made diagnoses that can be done. For example, if you're an adenoid cystic carcinoma like carcinoma in positive for P16 in the nasopharynx or oropharynx, you have a much different prognosis as opposed to a retinoblastoma in a child behind the orbit. So there is a high response rate to very specifically designed adjuvant chemotherapy. So here are some examples of round cell tumors, including primary extraskeletal round cell tumors, and these include extraskeletal, which means outside the bone. Okay, so rhabdomyosarcoma is the prototypical example of a round blue cell malignancy. And for me, if somebody tells me, here is a slide, and this is a round cell malignancy, what do you think of? My first thought is Ewing sarcoma, if it's a child. So that is another very good example of a classic prototypical round blue cell malignancy. Then comes desmoplastic, then there's undifferentiated, then sarcomas can have a round cell component such as rhabdomyosarcoma, but you can also have it in liposarcoma, synovial sarcoma, chondrosarcoma, etc., etc. You can also have a whole group of non-sarcomatous small round cell tumors such as lymphoma, leukemia, neuroblastoma, melanoma, and then everywhere you add the word small, it becomes a small tumor, small round cell tumor. You just have to add the classic example is small cell carcinoma of lung. Small cell lung carcinoma, one of the most common malignancies in the world, especially in people who are vulnerable to it, such as smokers. Okay, so this is probably one of the most important slides, and maybe you can, by the way, this information is all available clearly on the net. Not much of it is mine. I just cobbled it all together. So here you have on the left side of the screen a small round cell tumor. You can do immunohistochemistry, identified as a sarcoma, which means your epithelial markers are negative, or you can have a non-sarcoma, and therefore there's so many of them. And if it's a sarcoma, you can either rule it as rhabdomyosarcoma or not rhabdomyosarcoma. If it's a rhabdomyosarcoma, you can go to embryonal rhabdomyosarcoma or alveolar rhabdomyosarcoma. If it's not rhabdomyosarcoma, then what can it be? Most of the time, it is Ewing sarcoma or one of those in the family of Ewing sarcoma. And this is where the greatest development, you could say, or cytogenetics is going on, is in this family. I'm using the word family very broadly. This is the Ewing sarcoma family, and there are so many new tumors that are coming up. And honestly, I don't know even one iota of the information is available on Ewing's group of sarcomas. And also, if you've noticed the word FISH, most of you know what it stands for, is fluorescent in situ hybridization. And it is absolutely critical in making diagnosis of these translocations and things like that. So remember, this slide sort of built in small round cell malignancy. Immunohistochemistry directs you to either sarcoma or a not sarcoma, and then you can have a melanoma or lymphoma, etc. And then once it's a sarcoma, then there's not much choice. Basically, you have rhabdomyosarcoma or the Ewing's group of sarcoma. Synovial sarcoma, being a round blue cell, is very rare and is fairly identifiable. So how do you classify these? So one of the ways you can classify this is on the basis of pattern or basis of size or basis of origin. Okay. So if it's a basis of pattern, those of you who have looked at study sets or have seen these tumors will be familiar with a diffuse pattern. Diffuse pattern can be seen. And by the way, when I show you the next subsequent slides, you might see they are across the board, have commonalities. So for example, You see the name Ewing sarcoma here because it has a diffuse pattern, but you also see words like Merkel cell carcinoma. Merkel cell carcinoma is a neuroendocrine carcinoma that principally arises on the skin. There's very sporadic cases reported in the oral cavity, and we have had 1 or 2 cases which we have published in the literature. And then comes lymphoma, which is also a classic diffuse blue cell malignancy, and then leukemic infiltrate. In fact, day before yesterday, an oral surgeon here locally, a good friend of mine, I mean, I would say friend, he's a student of mine. He had a patient with CLL, 87 years old, and has a massive ulcer on the roof of the mouth, and took a biopsy. Unfortunately, the biopsy is all necrotic. So I had a conversation with him yesterday, telling him, I think it could be leukemia, but I'm not sure. Do you want me to stain? Because I have no other way to stain it. Or you can have a septate or lobulated pattern. The classic example again, you see the same repetition. The classic example of lobulated pattern of round blue cell is alveolar rhabdomyosarcoma. In fact, the word alveolar means it is arranged in alveoli, like in the lungs, which means in small compartments or air sacs, or at least some sort of empty spots. Then comes alveolar or pseudo-alveolar pattern. Again, of course, alveolar rhabdomyosarcoma. And then there is this old tumor known as PNET. I don't know if you remember, it was known as the acronym with PNET, primitive neuroectodermal tumor. These are typically seen in children, are absolutely devastating tumors. Then you can have a rosette pattern. There are several tumors, but the classic example is neuroblastoma. Neuroblastoma produces these beautiful flower-like structures, which are known as Flexner, Winterstein, or Homer-Wright rosettes. That doesn't mean they're specifically limited to neuroblastoma. You can see rosettes in many other tumors, but it is possible that you see a round blue cell malignancy coming from the hard palate or poking through an extraction socket on, the first maxillary molar has been extracted in an older person and a tumor is sticking out. Or a child presents with a maxillary mass, of course, unfortunately ends up being a neuroblastoma. Those are all possible, and you might end up getting to see a biopsy that looks like has produced rosettes on it. Then, Then you have a hemangiopericytoma-like pattern, which means you have various staghorn blood vessels, which means you get blood vessels that looks like the horns of a deer. So if you just imagine, I'll show you some examples where you might get to see this. Then you can get a pseudoglandular pattern, okay, where it looks like glands. And this is classic example is synovial sarcoma.
Come.
All right, somebody has to mute their microphone. I don't want to call you out by name, but thank you. It happens. Please don't feel bad. It happens. I've done it myself with my dogs barking. So you can have some cartilage in the middle of round blue cells. And that is classic example is mesenchymal cornerstone. So this is a given diagnosis. Do you see balls of cartilage like popcorn sticking in the middle of a round blue cell pattern? Your diagnosis is made. You may not need to do very much of IHC. Okay, so you see, we have already come to A, B, C, D, E, F, G. We've covered 7 entities already, 7 different patterns. Then comes classification on the basis of the size. If you have small round cells, typically you think of things like melanoma, lymphoma, Ewing sarcoma, neuroendocrine carcinoma, or sometimes a neuroblastoma. But as you can see, the laundry list that is in front of you, it is endless. But have you noticed now you start to see an overlap? I'm going to go back very quickly, but I want to imprint this into your heads, especially if you are an oral pathology resident. This is a good lesson to learn, okay? You have Look at the different kinds of patterns we have come through. Diffuse pattern, you saw lymphoma. Okay, you saw rhabdomyosarcoma, you saw Ewing sarcoma. On a septate, you saw Ewing sarcoma. You saw alveolar rhabdosarcoma. You saw neuroblastoma in a rosette pattern or a flower-like pattern. You saw neuroblastoma. Then we again saw things like synovial sarcoma. This is the only one that is an absolute unique. That one, and I would also tell you pseudoglands. If you see a pseudoglandular pattern, think of synovial sarcoma. Other than that, look at the repetition. We talked about these in other areas, in alveolar pattern, in small round cell, large round cell. So there's a lot of repetition. So just because you are a smart person and you remember patterns because you've seen maybe, let's say, 10 cases of a certain thing, pattern alone doesn't help you. So now we go to the basis of size. You see, again, you can have Ewing sarcoma, lymphoma, you can have a neuroendocrine carcinoma, then you can have large cells, round cells. And large round cells could be melanoma, or again, we're repeating, look at that, rhabdomyosarcoma, or some kind of a lymphoid tumor. And of course, large cells typically mean more epithelioid. It could be a poorly differentiated squamous, very poorly differentiated squamous cell carcinoma that can look like it has large round cells. Then you can have on the origin. And so of all the classifications I talked about, this is my favorite. So if I have to do anything, this is where not just me, all pathologists should try to establish, oh, so this is the origin. If you now go back to the oncologist or whoever, let's say the dentist who sent you the piece of tissue, or it came from your own oral surgery department, or came from your local hospital, and because it's an oral tumor, the general pathologist is asking you to come and look at it. By the way, that is a common pattern in my practice. Okay, we get medical pathologists in our institution, which is University of Florida College of Medicine and Dentistry, often ask us to come. They actually send the slides over to us for an opinion. You could say it is a courtesy. You could say as a routine. You know, it's become habitual for them to consult us on. So we do get to see tumors that have come into the oral cavity. And sometimes in United States, it is the call of the surgeon. So the oral surgeon who typically does these biopsies has a lot more clout than in Asian countries, where you may not be able to dictate who sees the tissue. Whereas in my scenario, we get a lot of oral surgeons saying, I would like you to read the biopsy. However, I would like you to send it to University of Florida, where we would get more people to, we would like an oral pathologist to look at it. So I'm not even going to discuss 90% of these tumors that I flashed across the screen from you. And I don't want you to get completely blown away, but do remember, how do you distinguish neurogenic origin? A simple immunohistochemistry, S100. There are other things, synaptophysin, chromogranin, but S100 is one of the most oldest, almost 100 years old. Okay, since 1950s, or even before that, S100 protein, which we know marks neuroendocrine. It's not a very specific marker, but it is a very important marker that marks things of neurogenic origin. And by neurogenic, by the way, it doesn't mean it has to come from the nerves itself. It comes from the neuroectoderm, the material that forms the spinal column. Anything that comes out of the neural crest will stain positive with S100, typically, unless it gets too poorly differentiated. Then you have mesenchymal origin, but mesenchymal, of course, has multiple different origins. One is, it is a muscle origin. So it may show a rhabdomyosarcoma, or it could be of bone origin, then you call it an osteosarcoma, or it could be of chondroid differentiation, then you call it a mesenchymal chondrosarcoma. So this is fairly self-explanatory when bone is seen or cartilage is seen, but when muscle is seen is not always very dependable. Let me tell you that. There are also some round cells that come from blood vessels, endothelial, like an angiosarcoma that is poorly differentiated. But I had very little experience with that, um, those entities, because they are not so commonly seen in the oral cavity. You can have, this is a mistaken typing here. It should not be chondroid, but actually lipoid or adipose differentiation, and you see liposarcoma. You can have a hematolymphoid origin and you have a lymphoma. You can have uncertain type, which is really no differentiation, and you can have all these unusual tumors, which we will not spend too much time on. Then let's talk a little bit about sinonasal tract. And you might say, I'm an oral pathologist. I don't think I'm going to see sinonasal tract. And I 100% agree with you. Neither do I. I see probably sinonasal tumors out of our monthly biopsy collection of, and again, I'm going back to 2019 numbers because this year is completely different. But let's say we get about 300 biopsies a week, let's say 1,000. Just to say 1,000 biopsies a month, just to make numbers easier, probably 20 of them are from the non-oral cavity. So you can see we are also very much secluded or inclusive of oral cavity. But you will, one important thing I want you to remember is when it comes to round blue cell tumors of the oral cavity, they are identical to the sinonasal tract. I'll repeat that again. Round blue cell malignancies of the sinonasal tract are very, very similar to the oral cavity. Therefore, reading or studying about the sinonasal tract makes more sense than studying. Let's say you are one of those studious oral pathology residents who pour through journals or read through textbooks. It is no use reading thoracic pathology or abdominal pathology or renal pathology, because that doesn't have too much anatomic similarity to the oral cavity, whereas this sinonasal tract, which means the nose, the antrum, the oropharyngeal tissue, all have very strong similarity with the oral cavity, and the similar kinds of structure and similar kinds of pathogens, similar kinds of pathogenesis affects the area. So therefore you should be familiar with this area, okay? The other issue which you and all of us in oral pathology world face is the third line. Biopsies are usually small and limited. You get a small snippet of a tissue that you get to see, and this is because the whole tumor may not be more than 2 centimeters in size. So typically the surgeon would like to send you a small piece so that you give them a diagnosis and they can then decide how much to excise or not. There is a wide diversity of both benign and malignant neoplasms in the sinonasal tract. And I'm not going to discuss any of the benign ones because usually they are identifiable, such as a hemangiopericytoma, etc. Some are more common than others and should be carefully excluded. So this is a good acronym to remember. This has been proposed by Dr. Lester Thompson, who is still actually the editor of Head and Neck Pathology, and absolutely incredible head and neck pathologist. He's not a DDS or dentally trained pathologist, but a MD or medical pathologist, and he gives the acronym Mr. Sleep or Mrs. Leap. Commit this to memory. If you haven't read his paper, this is a straight quote out of his paper. I'm literally copying and pasting. So this material that you're looking at, as I said before when I started, this is not my own material. This is all material that is available widely in the internet and other textbooks and journals. So the most important of the M is melanoma. Okay. R is rhabdomyosarcoma. S, squamous cell carcinoma. L, lymphoma. E, esthesioneuroblastoma, or also known as olfactory neuroblastoma. E, Ewing sarcoma. P, plasmacytoma. Okay, which is basically multiple myeloma. I would sort of strike out this P, small cell osteosarcoma, and mesenchymal condyle. Mesenchymal chondrosarcoma is very identifiable for the most part. Some people who don't like Mr. Sleep can also go with Mrs. Sleep, as long as you remember MR, SL, EEP. Okay, that is your prototypical round blue cell malignancy of the oral cavity as well. Okay, I'll repeat it again. Melanoma, rhabdomyosarcoma, squamous cell carcinoma, lymphoma, esthesioneuroblastoma or olfactory neuroblastoma, Ewing sarcoma, and plasmacytoma. So what is the role of immunohistochemistry? Immunohistochemistry is absolutely critical in making sure that you know what is the line of differentiation, what is the lineage of the cell, what is the pedigree, where is it coming from, is it lymphoid, is it muscle, is it neurogenic, and we talked a little bit about it. So immunohistochemistry in small round cell tumor diagnosis is absolutely critical to distinguish from sarcoma versus non-sarcoma, and I showed you a flow chart, if you remember, going back in the beginning of the presentation, that can help you distinguish between lymphoma, non-lymphoma, sarcoma, non-sarcoma, or carcinoma and sarcoma. And then if it's sarcoma, then you go to rhabdomyosarcoma or synovial sarcoma, etc., etc. So you do need immunohistochemistry to even begin with. And you might say, you know, my institution is poor, or overall, I'm very familiar that how, you know, in India, how your hands are tied in terms of getting immunohistochemistry. It is getting better. It is getting better than last 2 decades. It has steadily improved in getting access to immunohistochemistry. Reagents have become cheaper. Your technologists have become better in getting these stains done. Tissue stabilization has gotten better. Fixation has become better, etc., etc. Of course, machines have come in, and newer and higher, better quality technology has entered the realm of pathology. So what should be my line? So absolutely, if you're taking notes, some of you might be taking screenshots, I know, but if you are like me and like to write down on a piece of paper, this is absolute Bible. Okay, there is no way you can go ahead without knowing this. If you ever want to make a diagnosis of a round blue cell malignancy, you need an epithelial marker. Without ifs, ands, or buts, you need an AE13, or which is known as pan-cytokeratin. Okay, you need a pan-cytokeratin, which is basically a broad spectrum keratin marker. Next, you need a neuroendocrine marker. Typically, people fluctuate between CD56 or they do synaptophysin. If you're wealthy or your institution or patient is wealthy, do both of them. Do a chromogranin or a CD56 or synaptophysin and a CD56. You do a broad spectrum keratin marker like AE13, which is my favorite. You do a neuroendocrine marker like synaptophysin or CD56. Next comes a muscle marker. Here you get into a little bit of trouble, but just to start with, I would stick with desmin. Okay, desmin is one of those skeletal muscle markers that is broad spectrum. Okay, then no alternative to S100 protein, and then a CD45, which is also known as pan-lymphoma marker. It marks all lymphocytic origin. Okay, so I'll repeat it again. You need a broad spectrum keratin marker, which is pan-cytokeratin like AE13, a neuroendocrine marker, typically CD56, and another one of those. Or you can just do CD56 or just do synaptophysin. A muscle marker like desmin, Of course, we'll talk a little bit about the other markers later, S100 protein and CD45, which is a broad spectrum lymphoma marker. This is a neurogenic marker. This is a neuroendocrine marker, a muscle marker, epithelial marker. You see, if you can remember this slide, sort of commit this to memory without having to refer to your cell phone, you already are a very good pathologist. This is all you need to know. So you can, those of you who have joined in now, if you have seen this slide, you can shut off the rest of the presentation. All right, so now let's go to some specific tumors, okay? Look at the screen in front of you. You can see Ewing sarcoma. The most important marker is CD99, which is on the corner here. Oh, sorry. Or rhabdomyosarcoma, which you can see is positive for desmin, and also positive for myogenic. Then let's come to lymphoma leukemia, which will be positive for CD45. I would not pay attention. So anything with a double plus is very strongly reactive, okay? Then let's come to, what else? Melanoma, look at that, S100, strongly reactive. So look at that, you've already isolated leukemia, lymphoma, synovial sarcoma, rhabdomyosarcoma, and you missed, because you know, I'm not showing you all the stain results, but you will get neuroendocrine carcinomas also by using a CD56. You will hit upon Ewing sarcoma, and the chances of you finding a neuroblastoma or a Wilms tumor, etc., are extremely rare, because like our practice, I'm using my practice standard practice. As you guys are joining in, make sure you mute your audio, okay? I don't mind seeing your faces, but please mute your audio. Role of molecular genetics. And you know, one of the reasons I'm asking you to mute your radio, your audio, is I'm speaking to you through earphones. So every little noise on your side crackles loudly in my ear. What is the role of molecular genetics? That's the other question that a lot of people ask. One of the most important things is round blue cell malignancies have relatively consistent, balanced, and preserved alterations. And I'll talk a little bit about that, but do you think we do it routinely on our biopsy specimens? No, we don't, because our lab does not do this. So, but it is becoming more and more and more important, and I think this will become just like today's date. We had, you know, we did not have immunohistochemistry before. 20 years ago, think about immunohistochemistry. We used to struggle to find these translocations and things like that. You have to remember that we had same kind of issues with now with gene fusions and their products. They are so specific for each tumor that they are routinely found in all of these tumors consistently. What I want you to remember is it's consistent. It is not like some of the rare lung cancers and things like that. What is the role of molecular genetics? One of the important things about molecular genetics is it helps identify where the translocation is happening, okay? And this is what leads to development of new immunohistochemistry. For example, today we can test a tumor for ALK positive, or is it ALK negative? If it is ALK positive, it is an inflammatory myofibroblastic tumor. It's an IAMT. If it is FLY1 positive, it is Ewing sarcoma. If it is TFE positive, and where did that come from? It came from these fusion proteins, okay? So you have to remember that every time you come across, you think, oh my God, this sounds very complicated. Somebody in some lab in the United States is developing that, or in Europe, or in China, or in India is developing that particular gene fusion protein into an IHC. And as soon as you develop that IHC, it becomes more, especially if it is very specific, it helps tremendously. for example, the classic translocations are EWSR1, FLY1. EWSR1 with FLY1 translocation is absolutely consistently preserved, but this EWSR gene, now we know, is right. You definitely need to mute some people. Thank you. All right. And you can see EWSR mutation also happens in desmoplastic round cell, small cell tumor. Of course, we don't get to see too many of this, so I'm not too worried about it. But as you can see, it also happens in liposarcoma. So you see, but they have these things, new translocations that they are adding to them. For example, there is a very well-known translocation called the HEY or HEY1 protein. Then there is the synovial sarcoma with the X-linked chromosome translocation, the synovial sarcoma X1 or X2 protein, then the alveolar rhabdomyosarcoma with the FOX01 protein. So there are a lot of these translocations which are consistent. I did not show you the whole laundry list of them. I just showed you a very specific few. I'm still hearing a lot of background noise. Thank you. All right. Importance of detecting translocation. Is that even important? One of the most important thing is you have, why is it? So people ask you, why? Why is it important? I know there are certain labs in Mumbai, certain labs in New Delhi, which can detect, or in Chennai or Bangalore that can detect translocations, but those are very expensive studies to do. Just in United States, some of them cost $3,000 to do. So you can imagine it becomes prohibitively expensive. Why is it important? Why are we trying to still do research on these translocations? One of the most important things is if you see an unusual morphologic variant. First of all, you see a neuroblastoma that doesn't look like a neuroblastoma. You see a lymphoma that doesn't look like a routine lymphoma. Or it has classic morphology, but an unusual age of a 42-year-old with a tumor that should be in a child. Or a child with a tumor that should be in an 80-year-old. Or an 80-year-old with a children's tumor, such as a neuroblastoma. So that is why it's so important to have these translocations. And the other thing is it's to distinguish between different kinds of sarcomas and their mimics. There are certain sarcomas that look like carcinomas and so on and so forth. So what are some of the non-sarcomatous round cell tumors? Let's talk about them. One of them is a small cell carcinoma. So now I'm done with the classification and giving you a general background. So the rest of the talk, I'm going to proceed at a slightly faster clip, okay? Definitely those of you joining in new into the lecture, please mute your microphones as soon as you come in. Because no matter what you try to do, there is always background noise. So small cell carcinoma, it's rare outside the lungs. It's almost always seen in the lungs. It's a very high grade malignancy with poor prognosis. And look at the head and neck is only 0.4. That means 1 out of 100. It's not even 1 out of 100 that occurs. And this is a beautiful example I found in literature. I have not had a small cell carcinoma of the oral cavity or head and neck. This is one in the Japanese literature, or from Japan actually. And this is an 80-year-old male with a neck mass. Face is asymmetrical, beautiful example of one. You can see the swelling here. Patient has a neck mass with a palatal mass. Surface is smooth, ulceration is absent. Look at the CT scan, shows a right maxillary mass with bone destruction, as you can see here. Okay? And then there's a huge enhancement on the neck on this T2 weighted image. As you can see, it shows a giant mass in the neck and the coronal region. Here is a PET scan that shows uptake in the neck, as well as in the pelvic bone, okay, and the vertebra. There is some uptake in the vertebra. Can I ask everyone to mute their micro? I hate to say this again and again. I feel bad. I know you're not doing it purposely, but if you, that means either you're not paying attention to the lecture. The simplest thing to do is just mute your mic. Thank you. Thank you so much. You know, your name shows up on the screen when your microphone is not muted. It's not I'm trying to target you, but anybody who makes noise or puts their video on, the first thing that shows up is your face. So what is the differential diagnosis for this case? If you ask me, so here, let's go back. You show me this picture and tell me, Dr. Bhattacharya, what do you think should be number one in my differential? I say, oh, the patient has a neck mass. Okay, first thought is lymphoma. Hard palatal mass, neck mets. Okay, next choice, especially if I'm looking at an Indian scenario, I would say squamous cell carcinoma. Simple squamous cell, garden variety squamous cell of the hard palate, or maybe coming from the sinus into the hard palate with a neck mass. Okay, and that clearly the neck mass looks pretty well developed. And the third choice I really would have is a metastatic malignancy coming from somewhere else. And anyway, long story short, this ended up being a neuroendocrine type small cell carcinoma. Here is a syncytial pattern of cells with small atypical cells. You can see why we call it a small round blue cell malignancy. These are all blue cells. So to the uninitiated or a non-pathologist, if I asked you to describe this, what would typical non-pathologist say? Oh, I see a lot of blue stuff, maybe a little bit of purple, and the rest of it is pink. And you know, the background looks empty, looks like air. So what was the main thing you see? I see a lot of blue. That means it's a round blue cell malignancy. Even in this slide from a publication, you can see, you can pick up mitoses, okay? These are, or apoptosis. This was positive for pancytokeratin. See, they did not do anything fancy. Of course, they did other stains, but look at this. Pancytokeratin was positive, and also it was positive for chromogranin, synaptophysin, CD56 automatically. Remember, going back to that Bible slide I told you, that very important Gita slide, or the Quran slide, okay, is CD56 is positive. This is an example of CD56. And pancytokeratin, you've already picked up something. What do you know about this? This is 1, a carcinoma. 2, it is of neuroendocrine origin. My diagnosis is made. I'm going to refer the patient to an oncologist. I'm going to tell the patient or patient's party, go see an oncologist. You have a neuroendocrine carcinoma. I'll let the oncologist know patient has a neuroendocrine carcinoma. I don't know where it's coming from. Could be metastatic, could be primary, but simple thing. All I needed was a pancytokeratin and a CD56. So what do you see morphologically? Same thing. You see enormous numbers of small cells, which are let me move this. Yeah. Okay. All right. If you joined just now, please mute your microphone. So you see small cells with high nucleus cytoplasmic ratios. You see all kinds of mitoses. Look at that. Mitosis. So very high mitotic index. You see some necrosis. You see some pseudo rosettes. You start to get a feeling that there is a pseudo rosette. Remember what I said about rosette pattern being neuroblastoma? I think by the time the month goes around, everybody's used to Zoom lectures and things like that. We will all get to the pattern. So when I launch a Zoom lecture with my students who I'm lecturing, there is a button you can click, Nadeem. It's called mute on entry. So nobody can unmute themselves when they come in. Anyway, so what is small cell neuroendocrine carcinoma? Why am I showing you this? Just because it's a very nice example. It's not because you're going to see one. This is a highly rare tumor. I don't think I've ever diagnosed one like this, or if I have seen one, I missed it. But I have got it in the right category, which means I've done cytokeratin, and I've done a neuroendocrine marker, I've done an S100, I have done a muscle marker, and I've done a CD45. CD45 muscle marker was negative. S100 was possibly negative or sometimes a little positive, but CD56 or synaptophysin was positive and cytokeratin was positive. There is central necrosis, balls of cells. Look at that. The cells are in a nested appearance, a sheet-like or nested appearance, and you get that, we call it salt and pepper chromatin. When you look at it on high power, somewhere around 20 to 40x on a microscope, you should start to see this nuclear dotting, which is increased chromatin material. And this is a sinonasal neuroendocrine carcinoma. Look at the staining with synaptophysin. Look at the staining. Panel C on the screen is synaptophysin. Panel D is TTF. And I am not very sure if you guys know what TTF is, but TTF is a thyroid factor which is expressed by most lung cancers. Paradoxically, it is expressed by lung cancers, and on the top, on the right side, which is panel B, you see cytokeratin. So you would have not missed it if you followed that seminal slide on the first panel. Okay, that's very important. Next, we come to melanoma, and melanoma is your classic example of small round blue cell malignancy. And what do you see in melanoma? You frequently see epidermal, atypical epithelial or epidermal melanocytes. Unfortunately, in United States, we get to see quite a few melanomas, and more, and this is besides today's lecture, more and more I'm seeing this in young people. In the month of April, early April, I diagnosed one in a 28-year-old girl on the preauricular skin. She has already received a definitive excision and is doing fine. So, sorry, it's very hot here, so I just got up to turn the fan on. Gainesville, Florida is almost as hot as New Delhi is right now, probably in the high, low 30s. Seen in adults, and very, very rarely melanoma is seen in 20. Why am I showing you melanoma? One of the things I want to stress upon you, when I was visiting with Dr. Sushmita and I remember Dr. Pravesh Mehra in New Delhi, they have quite a few cases of, also the military hospital. In Kolkata, Command Hospital, I remember seeing posters and pictures of intraoral and intranasal and sinonasal oropharyngeal melanoma. Though skin melanoma is almost unheard of in the Indian and subcontinental population, you do see oral melanomas, even though it is extremely rare. Thank you. Oral melanoma, the diagnosis is often delayed due to silent growth and development of the lesion, and there's poor prognosis. Okay, so I wanted to show you one of our patients. Patient has a ulceration and swelling of the hard palate, and you can see a pretty ugly ulcerative granulomatous looking lesion that is involving the anterior hard palate. The only place where you really see pigment is the very anterior part in the rugae area or the incisive canal area. Patient has a history of smoking. Again, my differential includes a this is clinical differential, includes a lymphoma or a salivary malignancy or melanoma or squamous cell. Okay, and this is the initial biopsy. You can see numerous atypical melanocytes And I'm not going to give you a lesson in diagnosing melanoma. If you have seen one, it is frightening to look at. I mean, as soon as you put the slide in, the difficult ones are the very subtle melanomas. This is clearly evident with these kind of melanocytes going up in the epithelium. It's almost a given diagnosis. It's not a very difficult diagnosis. Okay, but what I want to stress on is look at this. When you look at a high power view, what do you see? Again, small, round, or maybe large, round blue cell malignancies. There is one important distinction point. Look at these nucleoli. We call them stoplight nucleoli. They look like little red lights on the street. Okay, even at this power, one of the most important things you see is the nested or organoid pattern. And you get these pleomorphic cells with prominent nucleoli. Start to see through, even with projections you're seeing on whatever kind of screen you're looking at, you should be able to start to see pick up nucleoli that are prominent and red. And I'll show you one more example. Here is a sheet of round blue cell. Look at that. Pleomorphism, hyperchromatic melanocytes, and look at these aggregates of melanin. If you see melanin, your diagnosis is made. It's not that difficult. So how do you stain melanoma? Through S100, HMB45, or SOX10. This is a new stain that we have been using quite a bit. It's much more sensitive and specific for melanocytes than S100. Okay, and of course, melanate. Here is an example of HMB45. By the way, the name HMB45 came from human male black. It was first a protein identified in a black male. I think it is 45 years old. I'm not 100% sure. And S100 protein, of course, is very positive in this case. Here is an example. This is another case, not this particular case that I'm showing you. This is from our own, my archive. And here is melanoma that does have some spindle cells, though. It's not all 100% round cells, but look at this, another example with melanate. It's a beautiful stain. The counter dye is red, so you can see orange or red stains with melanate. Genetic mutation, the classic one present is BRAF. Why do I mention this? One important thing that you need to know is KIT mutations are found. Look at the third line. KIT mutations are found with greater frequency for oral melanomas, unlike BRAF or NRAS. By the way, BRAF is becoming more and more well-known. This BRAF mutation is now being treated by anti-BRAF. So you can block BRAF. There's a medications called dabrafenib and other medications that are coming out. And that is a topic for another day. I can discuss. My personal interest is medications and their effect in oral cavities. So I do love to read about medications and what they do. And one of the things is now a lot of these expensive new chemotherapy medications that are anti-neoplastic are targeted towards certain molecules, and one of the biggest ones is now in United States, especially given the frequency of melanoma, is anti-BRAF medication. Okay, so what does this mean? KIT mutations occur independently from BRAF and NRAS. Therefore, why is this important? Because that's why people who get skin mutation, we know it's sunlight. It's UVB radiation, sunlight, or ultraviolet radiation that can cause it, or even a nuclear, accidents and radiation, etc., can cause melanomas. But the most important one is oral melanomas, a completely different pathway, and that proves that if there is a KIT mutation, it cannot be treated with an anti-BRAF medication. So chemotherapy, etc., may not work. You may have to radiate the patient. Here is an example of another melanoma, and you see this beautiful perivascular collection of melanocytes, blue cells, small round blue cell malignancy, the prototypical example. Sorry. Lymphomas. One line I have put down in yellow to highlight it. I've highlighted that line because you cannot make a lymphoma. You cannot even go ahead. All you can say is this is a lymphoproliferative disease on your diagnosis line. That's all. And again, my institution, somewhat from my own interest, we have done a lot of work on lymphomas in the oral cavity. Here is an example of a slide that I want you to sort of summarize, but so if I have to highlight a couple of malignancies that are more common in the oral cavity, One I want you to pay attention to is the extranodal marginal zone lymphoma. Extranodal marginal zone lymphoma, also known as mucosa associated lymphoma or MALT lymphoma, and then mantle zone lymphoma. Mantle cell lymphoma is positive for cyclin D1, which is a cell cycle controlling protein. And then many of these things came up from other things. That is the most interesting part. Today it sounds complicated, but if you keep one particular chart in your if you are a resident or a graduate, I think you call PG student. If you're a PG student, have a chart printed out. Print it out in color if you can. Put it up in your office or your room where you sit and study. It is, excuse me, it's extremely helpful in keeping this in mind. The other one is, let's see, another one, if I can highlight another one. The more common ones are follicular lymphoma. Follicular lymphoma, if you go back, you can see are positive for CD20. Everything is positive for CD20 because these are all B cell markers. So these are all B cell positive tumors, but there are certain other, for example, BCL2 is an anti-apoptotic protein, and so on and so forth. And I'm not going to go too much into lymphoma. All I'm doing is just showing you some examples of stains that are positive. So look at follicular lymphoma, may or may not be positive for CD3, but it's positive for CD10. You can again see translocations in some lymphoma which are preserved. So if you do a T11-14 translocation study and it proves that mantle cell patients' prognosis is extremely dire. Mantle cell lymphomas are terrible lymphomas to have. Follicular lymphomas, on the other hand, are, I don't mean to sound, dismissive, but follicular lymphomas are better lymphomas to have. And as in more and more pesticides and insecticides and fertilizers that our food is adding on to ourselves, we are getting more and more lymphomas. At least CDC estimates from United States is all malignancies have taken a backseat, which means they are starting to slide, including breast cancer. You might say, oh no, there are a lot more breast cancer. I know I'm going way over my time. So let me know, Dr. Nadeem, when you want me to stop, because I have a lot more slides left. So I can stop after lymphoma and take your questions, and maybe some other day in the future, complete this lecture, because this is going to take too much of time. I'm sorry, I didn't realize that I have so much more to cover.
I think you can go ahead, sir, for some more time.
You're okay?
Yeah.
Fine.
Dr. Indranil, you can continue for some more time, I guess, and maybe
Okay.
a little more fast because we don't want to miss out on anything. It's very,
Okay.
very sensitive. Okay. Thank you.
All right. So you can see some deletions in 11-14, and you can see how it can get confusing. You see this lymphoma, lymphoplastic plasmacytic lymphoma and mantle cell lymphoma have the same translocation. But lymphoma, we still haven't done too much of work. Then comes, this is from our own paper, my own paper in head and neck pathology. But actually the data, this chart is not mine. It comes from the Hans classification, the big lymphoma study group in Nebraska. But basically, I always run a CD10. Any oral lymphoma, I run a CD10. If it is positive, right away, we know it's a germinal center origin. But if it is negative, then you have to run a BCL6, and BCL6, if it is, so why is it important? You can say germinal center B cell origin or non-germinal center. Anything that is germinal center B cell origin has better prognosis than non-germinal center B cell origin. So if you remember the anatomy of a lymph node, and I'm not going to go too much into detail, I just briefly want to mention to you that if you have going to remember the germinal center, so any lymphocyte that originates from around the germinal center is called germinal center origin. Anything that arises from the mantle zone or from the surrounding structure of the lymph node is called non-germinal center, and those tend to have poorer prognosis than germinal center. And this is one of my patients that we published later in Journal of Hematologic Malignancies. This was ALK negative anaplastic. Believe it or not, I didn't put the subsequent photograph in, but this also just disappeared, just completely disappeared. That's why we published the paper calling it anaplastic large cell lymphoma showing spontaneous regression. Okay, so many of these people here are my residents when they were training. This is at least 10 years old, this publication, but this is a spectacular case that showed spontaneous regression of a lymphoma. So don't feel too bad if you have called something lymphoma and the oral surgeon or the clinician calls you back. I don't know what kind of interaction most pathologists have with oncologists, but here we do get some feedback. And the oral surgeon called me back. This is the gentleman here, Dr. Fox. He calls me back and says, believe it or not, the lesion is gone. Are you sure it's a lymphoma? And at that point, I couldn't back out. We've already signed the diagnosis out. And then I started looking into these, and these do disappear. These do disappear, these large cell lymphomas, and this was a round cell malignancy. Here is another example, floor of the mouth. See it bulging out, coming out of the mandible. Here's another one on the roof of the mouth, coming from posterior lateral hard palate, actually slash soft palate. Here is an example of a large cell, sort of pleomorphic blue cell malignancy. And typically, you see diffuse large B-cell lymphoma, CD20 positive routinely. Remember, I told you CD20 is another one, or CD45, just to confirm a lymphoma. Classic example. The two slides you see on the top, the two panels, are absolute classic examples. But if I told you, I showed you the same slide and told you, you know what, this is a rhabdomyosarcoma, you would not have no choice but to believe me. Not just because I am lecturing to you, or I have more experience than some of you. It is because we don't know. Therefore, you need a panel of stains. Okay. Here is an example from a specific type of lymphoma called Burkitt lymphoma. And Burkitt lymphoma, by the way, you've noticed we have dropped the apostrophe. So the world over, WHO is now recommending you do not have to call it Burkitt's lymphoma. You don't have to call it Sjogren's syndrome. You can just say Sjogren's or Sjogren's syndrome. You don't have to call it Wegener's granulomatosis, but just Wegener granulomatosis. In fact, that has also changed, by the way. We no longer call Wegener granulomatosis. I know I'm straying off topic. Okay. Just to show you examples, what are some translocations that have now become immunohistochemistry? Here is CMYC. Here is Ki67, also known as MIB1. This is a proliferation index. Look at the D blue C of blue cells. Neuroblastoma, commonly seen in children, more common in male children than in female children. It does occur in adults, but you can see it occur in the head and neck. Here is a huge mass that shows complete destruction, and it's pushed into the orbit, causing all kinds of problems, including the skull-based patient has very poor prognosis, only a 10-year-old child. And this is the classic Homer-Wright rosettes that it produces. Okay, look at all the mitoses. Neuroblastomas, as the name suggests, is a blastic tumor, which means arises from primitive cells. Anything that is primitive is blastic. Okay, so you get these beautiful Homer-Wright rosette formations, which are easy to identify if you get a good prepared slide. Here are some more examples. Deep red, round blue cell, sort of round, some are pleomorphic. Here are some staining, and here's beautiful Homer-Wright rosettes. So your stain, see, you would not have missed this diagnosis. If in a child biopsy, you saw synaptophysin or CD56 positive, which are neuroendocrine markers, you would not have missed it. This is, on the top is neuron-specific enolase, on the bottom is chromogranin, both of which show diffuse reactivity. Here is CD56. Absolute gorgeous example of one. It's a cytoplasmic stain, therefore you see the nuclei is not picking up the stain. S100 protein does not highlight, but it does highlight the fibrillary neural protein that is seen around these nests of cells. Synaptophysin is diffusely positive, again a cytoplasmic and membranous stain, more so than a nuclear stain. Just to show you olfactory neuroblastoma, this is in the head, usually occurs in the nose in older people. This is an older gentleman who had this, but not all of them present with beautiful histology. There might be tumor necrosis, spindle cells, etc., but it's generally considered to be a good example of round blue cell malignancy. Here is another example of olfactory neuroblastoma. You can see lobules separated from each other. Why do these tend to separate? Remember, they are trying to recapitulate neural formations. Neurons are separated by axons and they get into bundles. Therefore, neural tumors also tend to separate into bundles, okay? You have a lot of abnormal mitoses and profound pleomorphism, atypical mitoses. Look at the beautiful slide panel D, which is on the right bottom corner. See the S100 highlighting the neurofibrillary protein that is on the side, whereas the others are CD56. Here's CD56, so you would not have missed the diagnosis, or you would have done a synaptophysin, you would have got the diagnosis. This just to show you the new, absolutely new 2020 classification of small round blue cell malignancies include Ewing sarcoma and then Ewing-like sarcoma. Okay, there is the chick DUX4 sarcoma. Why is it important? All of these have significant prognostic differences. These tumors towards the end are all fusion positive sarcomas, and these have worse prognosis than Ewing sarcoma, which has the classic EWSR1 mutation. So just to show you an example or two, here is the classic, again, Homer Wright rosette. Remember, they are neuroendocrine. Anytime you see rosettes, it means cells are trying to organize around a certain neural component. Okay, sheets of small round blue cells with uniform round to ovoid nuclei. Look at this. Prototypical example of round blue cell malignancy is Ewing sarcoma. Monotonous round cell with an unusual adamantinoma or a meloblastoma-like pattern. This happens, but you don't get that palisading. It has too many mitoses, too ugly to look at overall. Therefore, you consider something else. You will throw your same panel that I talked about at first. Okay, you get CD56 positive. Here is CD99, which is the diagnostic stain, CD99. Once you get some neuroendocrine marker positive, CD99 is strongly positive. Here's another example. Here is the previous one. Look at how it misses the nuclei. Then look at this, positive. You get necrosis, small round, atypical round, diffuse round. You can get a nested pattern. You can get an alveolar pattern. And then I'm going to stop here and take questions. Rhabdomyosarcoma was my last entity, but I have quite a few slides.